All right, so we're moving on to a few other respiratory infections. We are starting the lower respiratory infections. We'll cover bronchiolitis, pneumonia, and SARS, which is known as severe acute respiratory syndrome. So let's look at bronchiolitis first. This is common in young kids. Now, this one is caused by respiratory syncytial virus. That's important to know. It's caused by respiratory syncytial virus, known as RSV. And this is transmitted by droplets, primarily in the winter months. And necrosis of the small bronchi and the bronchioles can cause edema, increased secretions, and this reflex bronchospasms that leads to this reflexive, spasmodic type of cough. Bronchiolitis has these manifestations of wheezing, dyspnea, which is difficulty in breathing, rapid or shallow respirations, that reflexive cough. Rales is seen, you kind of see the chest retract, the ribs, the intercostal muscles have a lot of difficulty, and you'll hear with the stethoscope crackling sounds. As they breathe in, it sounds like just crackles. There's fever, malaise, and atelectasis from the obstruction. Atelectasis is when the alveoli are empty. Okay, the treatment here is really supportive and symptomatic care. So we saw this slide before in the last lecture where we went over croup and epiglottis. Now let's add bronchiolitis into the mix because these all affect children. It's just at different phases. So the bronchiolitis is typically before the first year of life, and it's an RSV. That's important to know. The pathology is inflammation of the mucosa of the bronchioles. If you remember, the bronchioles is deep in the lungs, and it'll obstruct these small passageways. The onset is gradual, and the signs are increasing dyspnea. They get that paroxysmal cough, the wheezing, the chest retractions, the flaring of the nares to try and get in oxygen, and we can hear the crackling sounds, the rales or the crackling sound with the stethoscope. Let's look at pneumonia. Pneumonia is a bacterial infection, but it could be viral and it could also be fungal. Of the lungs that causes the alveoli to fill up with fluid or pus. And typically they'll say, oh, there's fluid on the lungs. Then they can see it on an x-ray, which is true. But it could be bacterial, viral, or a fungal infection of the lungs that causes the alveoli to fill up with fluid or pus. It may be primary acute condition of the lungs or secondary to another respiratory or systemic condition. It may follow aspiration or any inflammation of the lung. The entry of the organisms can be through a direct inhalation, a resident bacteria that spreads along the mucosal pathway, aspiration of secretions, or bloodborne as well. The classification of pneumonia is based on the causative agent, right? Is it viral? Is it bacterial? Is it fungal? The anatomical location, is it throughout both lungs? Or is it consolidated in just one lobe? Then you'll hear the word lobar. Is the pathophysiological changes, does it involve the interstitial tissue? Does it involve the alveolar septae or the alveoli? And epidemiological data, it can come from a hospital. They call that nosocomial. That's if it comes from a hospital, or it could be community-based where it's acquired. So hospital-acquired, nosocomial, or community-based. Let's look at lobar pneumonia. Now, lobar pneumonia is referred to as pneumococcal pneumonia. Pneumococcal pneumonia. This is a bacterial pneumonia. It's community-based. It's often in healthy young adults, and it's caused by Streptococcus pneumonia. This one can be localized. The infection is localized in one or more lobes. The inflammation and vascular congestion can cause exudate that forms in the alveoli, and that can create a consolidation effect that we can see on an X-ray. The exudate contains neutrophils and erythrocytes, these red blood cells, and fibrin that forms a little bit of a solid mass. The fact that the erythrocytes are there, the exudate can also produce a rusty sputum, and the rust color is coming from the red blood cells, from the erythrocytes. So that is a really important feature to know. So it could be consolidation that you can see on an X-ray. The exudate contains neutrophils, the white blood cell, but also erythrocytes and fibrin, and the exudate can produce that rusty sputum. Empyema, not emphysema, but empyema is an infection that can spread to the pleural cavity. Here is pleural consolidation. So if we look at the X-ray on top, here is the person's right lung. Here is the left. How do I know that? Well, there's two features here that tell me right versus left. Right up here in the corner, I'm cheating, I could see a little L. Most X-rays should have markers, but if they don't, there's another way to cheat to find out. Okay, one of them is look at the heart shadow. So here is the arch of the aorta, and here's the heart. So here's the apex of the heart. We know that the heart is more on the left side. Here's the diaphragm. And then on the left-hand side, we have the stomach. So this little air bubble is called a gastric air bubble. So that's typically on the left side. So even if we didn't see a little bit of that L for the left marker, we know that the heart and the gastric air bubble is primarily on the left. So this is the left lung. Here is the right lung. When we look down here at the bottom, this is an abnormal chest X-ray. And you could see that there is consolidation from pneumonia in the right lung here, primarily in the inferior lobe and in the middle lobe. The upper lobe is still uninfected. Remember, the right lung has an upper lobe, middle, and lower, whereas the left lung only has an upper and a lower. There is no middle lobe on the left-hand side. So here is, if we look at lobar pneumonia, and this one, this is affecting just one lobe, okay? You could see the consolidation here. There's a pleurisy, there's bacterial accumulation and buildup. We're going to get into bronchopneumonia, which we can see on this side. And then we'll get a little bit into the primary atypical pneumonia. Okay. Here we can see from this cut, we can see the upper lobe, the middle lobe, and the lower lobe. We can see the primary bronchus. Then we can see the secondary bronchi here, and then we could see the tertiary all the way at the end. Okay. So with lobar pneumonia, this has a sudden onset. There are systemic signs as high fever with chills, fatigue, and increased white blood cells. There's dyspnea, difficulty in breathing, tachypnea, which is increase in respiratory rate. Tachycardia is the increase in the heart rate. There is rales, which are the crackling sounds that you can hear with a stethoscope. And there is a productive cough. Typical rusty colored sputum with lobar pneumonia. This is typically treated with antibacterial medications. With bronchopneumonia, this one has a diffuse pattern of infection in both lungs. Okay, it's more diffuse pattern. in both lungs, commonly in the lower lobes. There are several species of microorganisms here that may be the cause. So what they'll do is they'll have to look and take a sample of the exudate and sample it to see what the causative bacteria is and then give the specific treatment for it. So there is an inflammatory exudate that forms in the alveoli. The onset here is a little bit slower, so we say it's insidious. There is moderate fever, there's cough and rales. This has a productive cough with purulent sputum, but this one's usually yellow or green. Okay, that is important to know. This one is yellowish and green. It also is a diffuse pattern of infection compared to the other one that was more localized in just that one lobe. Okay, so here we have bronchial pneumonia. This one's more diffuse. We could see that it is spreading into not just the lower lobe, but now it looks like it's also spread into the middle lobe. When we looked at the lobar pneumonia, that was pretty much consolidated and localized in just this one lobe. So bronchial pneumonia could be diffuse. It can spread into multiple lobes. Okay, Legionnaire's disease, this one's interesting. This one we typically hear quite a bit in the summertime, in the warmer months, because this one tends to thrive in warm, moist environments. It likes the air conditioning units. It likes spas. This one is often nosocomial infection, which can be spread in hospitals. That's an important feature to Legionnaire's, nosocomial. This one, it lingers in these air conditioning units. And then as the air pushes out through the vents and people breathe them, they can get Legionnaire's. This one causes severe congestion. It also causes consolidation. There could be necrosis that forms in the lungs, and it could be possibly fatal. The PAP, the primary atypical pneumonia, this is what most people refer to as walking pneumonia. The causative agent is Mycoplasma pneumonia. It's a bacterial infection, common in older kids and young adults. This too is transmitted by aerosol. It's not very contagious. The most prominent sign is just frequent cough, and this one is treated with antibiotic therapy. For the PAP, for the primary atypical pneumonia, the causative organism could be a viral form of viral pneumonia, and this one's caused by influenza A or influenza type B or the adenoviruses and the RSV, the respiratory syncytial virus. This one has an unproductive cough. There's hoarseness, sore throat, headache, mild fever, and malaise. Chlamydial pneumonia, this is caused by chlamydia pneumonia. This is a very mild form of pneumonia, and it often goes undiagnosed. So here is the primary atypical pneumonia. You can see it's kind of interstitial, and it can be caused by the mycoplasma. So here you can look at lobar pneumonia. The lobar pneumonia could be all of one lobe or two lobes. The bronchopneumonia is scattered small patches. This one can be more diffuse, and the PAP can also be scattered in small patches. The lobar pneumonia is streptococcal pneumonia. The bronchopneumonia could be multiple, and the PAP is the influenza virus or mycoplasma. The pathophysiology with lobar pneumonia, this is the inflammation of the alveolar wall and the leakage of the cells, the fibrin, the fluid into the alveola, causing consolidation. Whereas in the bronchopneumonia, There's inflammation and purulent exudate in the alveola. They're often arising from the prior pooled secretions or irritation. The PAP has the interstitial inflammation around the alveoli. This one has necrosis of the bronchial epithelium. The lobar is more acute, it's sudden. The bronchopneumonia is more insidious, and the PAP can vary. When you have lobar pneumonia, there's high fever and chills. With bronchopneumonia, it's mild fever. And with PAP, it can vary. With lobar pneumonia, this one gives the productive cough, but this one has the rusty sputum because of the red blood cells that infiltrate as well. This one has the rales, that sound of the crackling sound with the stethoscope. With the bronchopneumonia, it's a productive cough, but unlike lobar pneumonia that's got the rusty red, this has the yellowish green sputum with dyspnea. The PAP has a non-productive cough, along with variable fever and achy muscles. Pneumocystis carinii pneumonia. This is a fungal infection which occurs with opportunistic infections, primarily with HIV patients and associated with AIDS. Okay, we'll finish up with SARS. This seems to be a hot topic lately. The SARS stands for Severe Acute Respiratory Syndrome, SARS. It is an acute respiratory infection, and the causative microbe is a virus that's called what we're dealing with now, especially the SARS-CoV-2. Okay, severe acute respiratory syndrome, coronavirus 2. The disease is coronavirus disease, COVID 2019. The transmission is through respiratory droplets, could come from close contact, and the first signs show between days 2 and 14. Fever, headache, muscle aches, myalgia, the chills, loss of appetite. There are GI signs, and sometimes the GI signs are the very first ones that show up. There's many labs that do stool testing that can pick up the SARS earlier sometimes than the respiratory droplets in the nose. There's also loss of smell and loss of taste, really important questions to ask. Not just assessing for fever, but loss of smell and taste. These happen to have an interesting connection with zinc. Zinc has a lot to do with smell and taste, and when there are zinc deficiencies, the immune system becomes quite compromised. Later, it can progress to the lungs. The lung signs become very evident where there's a dry cough, there's marked dyspnea, there's areas of interstitial congestion, hypoxia, and in severe conditions, mechanical ventilation may be required. There is a high fatality rate with people with pre-existing conditions. So they would typically call this a syndemic. I know people use the word pandemic, but a syndemic is when there's many epidemics happening at one time. So we'll see this not only in the elderly, but the immune compromised, people with diabetes, people with asthma, people with cardiovascular diseases, and things of that nature. The treatment here is going to be antivirals, glucocorticoids, and prophylactically and proactively, this is something I have a majority of my patients on. I'm taking it as a healthcare provider. I take them every day. I'm around lots of people and my children as well. Zinc. And we take zinc, sometimes with elderberry and some chewable forms. My kids like the chewable ones. I alternate between the zinc lozenge on one day, and then the very next day I'll use just a zinc glycinate capsule. And vitamin C, um, can take vitamin C liposomally, can take it as a chewable, can also take it as a capsule. Vitamin A, also very beneficial. A lot of research showing vitamin A has been helpful. Glutathione as an antioxidant. I happen to like to use glutathione liposomally. It dissolves in the mouth and gets right into circulation. And then NAC, N-acetylcysteine. Um, a lot of research shows that NAC, when you consume cysteine, that is the weak link in the body's ability to produce glutathione, because glutathione is made up of glycine, glutamine, and cysteine is the weak link. There are risk factors, which is traveling to endemic or epidemic areas and close contact with such as a traveler, which is why there's lots of quarantine periods associated with traveling to or traveling from certain states that may have a current clustering effect. And also employment involving close contact with the virus. This is just an illustration that shows how the virus is actually produced and spread. If we take a look at it, you'll see that here is the viral membrane, and then we have the nuclear caspid encapsulating the viral RNA. There's the envelope. There are these spike proteins going around it. Corona, like crown, right? These spikes of a crown. So here we have SARS-CoV-2, and we can see that it is binding to an ACE2 receptor. And there are many organs that have ACE2 receptors. The heart has them, the lungs have them, the kidneys, the liver. So this can target a variety of organs. And then it binds to enter the body through the cell membrane, and the method of engulfing it is called endocytosis. And you can see that this is the host ribosome, and there's the release of the viral genome, and then there's translation of the viral polymerase protein, and then there's replication of the genomic and subgenomic RNA, and it will transcribe for the envelope, right, for the membrane, for the spike proteins, and it enters the endoplasmic reticulum, where it combines with viral proteins. Then that's pushed out into the Golgi complex or Golgi apparatus, where it repackages it, and here we have the virus inside the Golgi vessel. And then the Golgi vessel, it's time, now that it's packaged, it's time to be released outside of that cell. So it starts to move toward the cell membrane, and it is released through exocytosis. Okay, and then this can move out, and it binds to other ACE2 receptors. So here, again, we can see the S protein, we can see these spikes, you can see the nuclear capsid protein, there's a glycomembrane, there's the envelope, lots of protein, and there's RNA. And the transmission pathway, it will be spread through respiratory droplets that could be greater than 5 micrometers, or droplet nuclei of less than 5 micrometers. And it sticks to the infected surface, to the respiratory, to the mucosal membranes on that ACE2 receptor. And you can see the binding of it, and then it progresses right into the lungs, and you can see that you have a whole bunch of cells. Here's the bronchus, here's the alveolus, this is the alveolar sac, and it tends to affect the type 2 cells that are involved with surfactant production to ensure proper respiration takes place and that the alveolar walls don't stick to each other. But their body starts to respond, right? Macrophages respond and dendritic cells respond, and then cytokines are released, pro-inflammatory cytokines, and then there's the accumulation, right? There's the leukotrienes and the prostaglandins involved, and the leukotrienes are involved in constricting the airways and the mucus production in the airways, and the prostaglandins are involved with fever and pain and inflammation, and fluid starts to accumulate here in the deep part of the alveoli. So people feel like they're trying to catch their breath or take a deep breath in, and they feel like they can't get enough air. Some of the therapeutic drugs, there's a plasma therapy, convalescent plasma therapy, hydroxychloroquine and chloroquine, remdesivir, nafamostat. So these seem to be many hospitals and doctors and many case studies showing success with these therapies, thank goodness. In terms of testing, they do this PCR testing where they can put a swab in the nasopharynx to go right to the back here. It's a little bit uncomfortable, it's a little bit awkward, and they extract the RNA from the specimen and convert it to DNA, and then they amplify by PCR with the SARS-CoV-2 specific primers, and then they interpret the results. The presence of the viral RNA indicates active SARS-CoV-2 infection. And then there's antibody testing, where they obtain a specimen or a blood sample, and then they expose the specimen to SARS-2, the SARS-CoV-2 specific antigens. And then they interpret the result based on the color change that indicates the previous exposure or current exposure. So previous or current, we can do the IgM or IgG rapid test, where here they do a pinprick, they use the pipette, they suction out the blood that's coming out of the fingertip, they put it into a dilution, they mix the dilution, then they use the pipette and they pull it out of here, the dilutant along with the blood. They drop it in here, they put the sample in here, and then they just wait and they look to see the results. So here's IgM, which checks for past exposure, and then here's the IgG for current exposure. This is a negative test. The blood sample would go in here, and then it moves upward. The C is for the challenge. So we want to see this test, which means it's a good, valid test. If the T for the test, if this line shows up in the IgM, it means they've had a past exposure. If there's nothing here, but it shows up on the IgG, then they have a current active exposure. Okay. All right. When we continue on the next lesson, we will start and continue on with some more lower respiratory infections. We'll talk about TB, histoplasmosis, and anthrax.